So one of the challenges we had at MedArrive, we did not have any problems proving clinical outcomes. That was, and any in-home care program, you're going to see hospital care at home, the mortality rate is minuscule compared to those same patients in a cohort in an acute care setting. You're going to see that people have much quicker recovery times in any kind of in-home care delivered well. And the reason for that in my mind, and this goes back to, again, my social work sort of background, I think one of the hardest things for chronically ill people is loneliness and the scariness of a chronic condition. I actually have an autoimmune disorder myself.
Welcome to Deep Current. I'm Andy Monge from Ocean's Code Experts. This show is about people building and operating the systems behind better healthcare. In this case, we have Greer Rios, Chief Operating Officer at MedArrive. So MedArrive is pretty cool. They're working on a really important space, helping health systems and healthcare providers and in-home care providers coordinate care delivery in the home through software, logistics, scheduling, routing, and real-time visibility. Did I say that correctly? Greer, welcome to the show.
Yeah, thanks, Andy. So glad to be here. Yeah, we are doing all of those things. And our founding principle is to get the right care at the right time to the right patient in the right setting. So we're doing, our platform builds tools and operates tools upstream and downstream of the actual visit. So predicting the right side of care for a patient who's in an acute setting, all the way to coordinating, getting them into that setting, and then coordinating the care as they're receiving care in their home or in whatever space it is that they call home.
This is great. Before we get into the nitty gritty about the platform per se, how about you tell us a little bit about your background? How do you end up working in this intersection between healthcare and healthcare operations?
Yeah, great. I graduated more years ago than I want to admit with a Bachelor of Social Work degree and worked in health systems doing discharge planning and social work for about 10 years. Then I moved around, did a couple of different things, eventually got an MBA and came back into project management, got into IT project management, and in the healthcare space, worked at Optum for about 8 years in the revenue cycle space, managing customers, technology and services solutions. And then I got the opportunity to join MedArrive. And along the way, I was a volunteer EMT in my community. So initially MedArrive was putting providers into homes before we realized that actually we had an opportunity to impact more people by offering the platform we built for ourselves. So, but when we were doing that model of putting patients in the home, we had social workers virtually, nurse practitioners virtually, and EMTs and paramedics in patients' homes. So for my background, this was an amazing opportunity to really start to unpack what's possible at home for people and just really match my passion. So very excited to be able to bring all of that background to the MedArrive opportunity into the healthcare space as we need to drive care more into the home.
That's fantastic. And how did you come to the healthcare operations side? Was it long ago, or if it's more, you're more on the technology, delivery, or it's a mix of everything right now?
It's kind of a mix. I've always been in some form or fashion part of operations because even as a project manager or working in the tech space, my background has always been to be a bridge between what's happening operationally and what the tech needs to do to support that. So, and actually I credit some of my social work background with being able to help people articulate what is the workflow that you're actually doing. So many times in my career, people are you're asking people to say, what is your workflow, right? You're trying to automate something, or in the days of AI now, right? We're trying to get AI to understand what are the tasks that are happening. And often when people do a job, they do it like they're breathing, right? So they don't actually really think through, most of us day to day, how do I do that task? So a lot of my career has been spent helping people really articulate what is that workflow. And then rather than automate exactly what people say in their answer, optimizing that workflow first and then automating it based on steps that could be removed or standardized or any of that. So that's I've always been in this operations/tech space in one way or another.
That's fantastic. I love it. In healthcare, how long ago? Since since MedArrive basically, or it's before that?
Healthcare. Yeah, I started my career in health systems. So
Okay.
I've been in healthcare almost 30 years.
Amazing. Fantastic.
Yeah.
Fantastic. That brings a lot of experience to the conversation, which is great. So for the listeners who may not know MedArrive well yet, I know you described it a little bit at the beginning, but can you describe what the company helps healthcare organizations do in a nutshell?
Yes. So we have two primary markets that we serve. One customer is a health system that needs to identify and expedite people from that acute setting to the next site of care. So a lot of us, if you go into the hospital and you have an operation or you have had some kind of emergency, many people go home and they don't have any needs when they go home from the hospital. But obviously lots of people do need to have extra help. They either need to go to a rehab or they need to go home with home health. And what happens is it's so funny that when I was doing the work of discharge planning 30 years ago, the work actually isn't that much different. A lot of case managers and discharge planners are still walking into a room with a paper notebook full of notes about the calls they've made that are all manual calls. They've been having conversations with families and providers in the community, and it's very manual and very administrative. And so that really prevents people from working at the top of their license where they could be having conversations with patients who are, for instance, having to face a hospice decision or really tough healthcare treatment options. So that administrative burden means that things are slow to get people out. So people are often clinically ready to go home, but they're waiting on a ride. They're waiting on their durable medical equipment. They're waiting on some other step to happen. So at MedArrive, we're doing two things around that for health systems. One is when a patient comes into the acute setting with their EHR data and with data from where else they've been in the community receiving healthcare, predicting using AI when they might be ready to discharge, and then scoring them against different types of care that they might need after their acute stay. So again, lots of people, no needs, but the people that do have needs, we score. Do you need rehab? Do you need skilled nursing? Do you need home health? And we just use the data that's updated in the chart by the physicians and the care team to update those scores as the patient stays there. And that then helps those case managers and discharge planners triage their patients so they know which patients do I need to talk to today. And then we also are automating the tasks that they're doing to get that patient to that next site of care. If you've ever had someone in the hospital like I have, my parents have both had stays in the hospital. I had an uncle who was recently in the hospital for quite some time. And it's really tough when you're clinically ready to go to the next place, but that the paperwork is what's holding you up. Hospitals are not a place you want to be in when you have fragile health conditions, right? There's infection risk. And then hospitals themselves, health systems need for patients they need that bed, right? They need that bed for the next person. So from everyone's perspective, getting people out when they're clinically ready to go is really important. So that's
Yes,
one
it's not.
side. Yeah,
No,
that's one side is the health system side. The other side is people that are operating a program. Health systems are operating these, home health is operating these. There's a whole continuum of care that's happening in the home that's being done by, again, health systems or home health. And managing those operations is extremely challenging. And that's the challenge we first solve for ourselves. So our Operate tool helps organizations, and we're doing this with hospital care at home, for instance, works for infusion at home, home health. But what that tool does is it says, all right, who are my caregivers? Where are they? Where are my patients? And how do I make the most efficient day? And then it also, in an automated way, can reshuffle the day so that, again, you're really, really making sure people aren't in the car. They're in a patient's home providing care. And we have a ton of tooling around that. We're showing a 13x ROI at a hospital care at home program just by freeing up capacity by doing some things that humans were having to do on spreadsheets to kind of operate the day.
that's fantastic. I love it. So it's two main verticals to help people discharge faster, to save time, money, and improve health in general.
Yes.
And
Yep.
then the logistics side, which is, I love it. I think it's very needed in today's industry, right? In today's world, especially since traffic keeps building up. Time we have less time, even though the day has the same 24 hours, right? But we do have less time. So I love it. This is fantastic. I was going to do like a follow-up question to this, but scratch that. I think that was perfect. I love it. So how does your typical week look like as a COO? I mean, not the polished job description, but like the real version.
Yeah, it's really interesting in the startup space. We're a relatively small team. So, CEOs of big organizations are probably dealing a little bit more with that large team, managing leaders of leaders and those kinds of things. And in my role in a startup, my job, I see my role as the COO, especially in a tech startup, is to make everyone else's job as easy as possible. I want our engineers to be focused all day long on engineering and not on meetings, not on paperwork of some kind, not on administrative tasks. So my role is to really support everyone else to have the tools they need, to have the frictionless day-to-day way to do their role so that we can maximize everyone's output. Day-to-day for me, especially in the last 2 years, that's really changed because of AI. So now I'm using a lot of AI tools just to manage the incoming traffic of the day and make sure I don't miss anything in Slack, anything in email, anything on my calendar. I do a lot of vendor management. I do a lot of, paying our bills, basic HR tasks. The fun thing about a startup is you kind of wear a bunch of different hats all day long, which I enjoy. And everybody has to have their sleeves rolled up. So because I also have a clinical healthcare background, I also lean in a lot on product. So I'm someone that the team will call and say, hey, I'm trying to decide whether the screen should do this or that. What do you think? I manage our customer relationships. So I kind of run the gamut. So really my day is about context switching kind of all day long between all of those different activities.
That's
Reviewing
interesting.
agreements, all of it. Yeah. Just all kinds of context switching, marketing,
Wow.
all the things.
I mean, it's kudos. I mean, that's tough to do, right? Doing a lot of stuff at the same time. I think my brain would probably explode, but amazing. That's fantastic. And would you say that you spend more time like on the health system partners, internal operations, maybe product, maybe implementations, or it's a mix of everything?
It's really kind of a mix of everything. Although I would say I think about it as, I think I learned this from the former CEO of MedArrive, Ina Plum, who's a good friend of mine. And she taught me early along the way in the startup world that you have to ruthlessly prioritize the day.
Mhm.
So when it comes to my world, I think about customers and teammates first, and then everything else is secondary to that. So if I have a choice in my day between customer and teammate issues, very first off the top, and then all the administrative things can usually wait. So I try to be really clear about what has to get done today to move our business forward and what can wait.
That's great. I love it. What tells you that an operation is working well?
I think the number one piece is how are your customers speaking about you? So I'm really grateful that we have very referenceable customers who, in fact, from our very first customer in the hospital care at home space, I often get texts that say, hey, I was talking to this company or this other health system, and I talked about the results we've had with you. So I'm not even having to ask for those references, that's success to me. I want our customers to be so happy they're out telling our story even before we are. But that's, to me, the other piece is just responsiveness. One of the things I think as a startup, though I've sort of always used this in my career, even at Optum, I think people miss that just being responsive to people quickly is one of the best ways to establish relationships, credibility, and to keep on top of things. So I'm ruthless again in the area of reaching back out to people, answering emails, making sure I'm, within that day or even within that hour, if I can, getting back to folks, especially on the important issues.
Amazing. I love it. I love the answer. So, what's the one thing that MedArrive has learned about in-home care delivery that people outside the industry usually underestimate, maybe?
Yeah. Oh, I love this question. So one of the challenges we had at MedArrive, we did not have any problems proving clinical outcomes. That was, and any in-home care program, you're going to see hospital care at home, the mortality rate is minuscule compared to those same patients in a cohort in an acute care setting. You're going to see that people have much quicker recovery times in any kind of in-home care delivered well. And the reason for that in my mind, and this goes back to, again, my social work sort of background, I think one of the hardest things for chronically ill people is loneliness and the scariness of a chronic condition. I actually have an autoimmune disorder myself, and I know from my own experience that when you have chronic pain or some kind of health challenge, and I know this also from my EMT experience, that 3 a.m. pain is a whole lot scarier than 3 p.m, right? 3
Yeah.
p.m, you're doing stuff, you're moving around. 3 a.m, you're by yourself, even if, your family's sleeping, and you're kind of in this debate about like, gosh, do I need to see someone? Do I not? When you know you have a caregiver coming the next day, you are much less likely to call 911 or wake everybody up and go to the ER because you know care is on the way. And so that loneliness piece as well was really important in our MedArrive journey and then with our customers today. There are so many stories about patients who, just by virtue of seeing someone who is caring about their condition, that alone helps people's health improve, helps their vital signs improve. It's amazing to watch. The other thing about care in the home that's magic is that when you're in someone's home, think about it when you're at the doctor's office. When you're at the doctor's office and the doctor's asking you a bunch of questions, you're already nervous, you're in a different setting, you're thinking about all kinds of things. You might not answer everything the way you would when you're sitting in the comfort of your own home and that caregiver can see what's going on. Over and over, when we went into patients' homes, we could see that their kitchen didn't have any food. They didn't have some of the basics that they needed to move around their space. They might need durable medical equipment or their durable medical equipment was broken. Some of those things that you wouldn't necessarily see in a clinical office setting. And so seeing people where they live just gives you so much more information about how they're actually doing. The other piece is when people are at home, again, if you think about just yourself, right?
Yeah.
You have your own food, you have your pet that's there, you have your family that's there, you're comfortable. You know, the TV works. Can't tell you how many times when my uncle was in the hospital for an extended stay, his TV in the room didn't work, which was, drove him crazy. All of that is much more comfortable when you're in your own space.
That makes so much sense. It's like the Patch Adams theory, right? That
Yeah.
if you're happier, if you're laughing, if you're comfortable, you're going to have a much better success rate on recovery. I love it.
Yeah.
So in this case, since you mentioned that, yeah, there's so many benefits, but there has to be operational challenges, right? Like healthcare organizations like face it when they try to move to in-home care. What is the biggest operational challenge in this case?
I mean, I think the biggest one is so we've built, right, lots of brick and mortar infrastructure across our country for healthcare, which unfortunately in rural areas, right, we see hospitals closing and we see some of that changing. But generally, by and large, we invested all this money in these physical buildings, and it is much more efficient to go see the care team in a brick and mortar setting where they stay where they are and see people back to back to back to back to back versus having those providers driving around a community. So just on its face, sending people into patients' homes is not efficient.
Mm-hmm.
So if you think about it too, it's different than Uber or DoorDash or any of those things because you're sending a care provider into someone's home to do something that's very personal. They're not dropping the food off at the front door. They're going inside. It's going to be intrusive. And for some people, that's kind of scary. In the hospital care at home side, for some patients, it's such a new idea that it's a little bit scary to think about, well, if I could be in the hospital, maybe I should be. Maybe I'm too nervous to be at home and have someone seeing me multiple times a day. I kind of feel safer in the hospital. Again, if you experience hospital care in the hospital, you realize it's actually, you're not seeing people all the time, right? You have a call button, takes a while for people to answer, all that kind of stuff. But operationally, it's a huge challenge to make getting around a patient's homes efficient, getting enough visits in the day to make an operation have a good ROI for the health system or for any of those care teams. And home health is struggling with this as well. In home health, the other challenge is, right, we all are seeing this really, really clear provider shortage across all of the aspects of healthcare. And not just providers. Now we're seeing shortages in even the administrative teams that need to do work in a health system that isn't clinical. So there's this huge workforce shortage compared to the number of patients we're going to continue to have. And in that space, in home health, one of the reasons people want to do home health as a provider is that they want control over their own schedule. So they don't necessarily want to be in a place where they're scheduled out for so many visits a day. Mm-hmm. One of the things we're really excited about is that in our tooling, providers can still set their own schedule, and our automated scheduling engine respects what the provider says is blocked off. That way you can have that centralized scheduling and you can really have the transparency around what's happening in your operation without trading provider satisfaction. So those are the two big things, right? Provider satisfaction and safety, as well as just the fundamental of driving around is not efficient.
So my follow-up question would be, when you talk about healthcare providers, that's clinics, hospitals, whoever that may be, and they can provide any type of individual. I won't say individual, but medical specialists like doctors, nurses. I don't know, whatever.
Yes. You mean in the home? Can they provide any of
Yeah,
that? Yeah.
yeah.
Yeah, there's a lot of care that's being driven into the home. One of the most interesting use cases in the last couple of years is this idea of getting infusion at home. So, if you have an cancer diagnosis, historically, what we've done is you've gone and you've seen this in movies and TV shows where people go and they sit in a big lounger and they're getting their treatment in some kind of clinic area sitting next to people. So in the last few years, they've started to move those infusion therapies into the home, which again is so much more comfortable than the patient who's sick with cancer and pain, having, side effects from medication, having to go to a place and be there for several hours. So that's an exciting specialty that's really starting to drive care into the home. Dialysis is happening in the home. Cardiac teams are starting to do remote patient monitoring in the home. So everyone in the health system is thinking about how do we get more care into the home because of the bed shortage that's going to happen. In 2030, we know for sure that most hospitals will be out of beds for elective surgeries because of the number of baby boomers that will be in their 80s at that time and needing the most healthcare. So there's this sort of shortage coming that everyone is aware of. We can't build our way out of it. It costs about $1 million to $10 million, depending on where you are, to build one hospital bed for a health
Wow.
system. So we can't make that expand enough to work. And with the reimbursement challenges healthcare systems are facing in the next couple of years, it started in 2027. uh, Health systems can't afford to be building more beds. In fact, they're closing those rural hospitals. So for rural patients, it's even worse, right? That's really
Wow.
hard to get inpatient care.
That's crazy. And you touched a spot there. My mom, when she had chemo, I remember her. I sometimes had to take her to those big rooms, and it was very uncomfortable for her. I remember if she had done it at home, it would have been much, much better. So,
Yeah.
and yeah, for rural patients, I hadn't even thought about that. That's crazy. It's a lot tougher for them to mobilize. Yeah, great, good. This is great. This is fantastic. So let's talk a little bit more about like the shift towards care at home. So there's a big industry push, I think, to move more care outside the hospital because of what you just said, right? Into make it into home, more comfortable, better results. On paper, I mean, it sounds fantastic. It's perfect, but more convenient for patients, potentially lower costs, more flexible. But operationally, it sounds like it's a nightmare. From your perspective, I mean, how how do they actually work? Is it true that they're actually working, that it's growing the industry?
It's a mix, honestly. So home health has been around for quite a while. Home health has been around for at least 100 years in this country where you have it. And that's when we think of in-home care, most people think about that home health model where a nurse or a caregiver, physical therapy, occupational therapy comes in a couple times a week, sees the person, does some treatment, and then the person is at home. And that is for people who are relatively mobile, they're relatively able to take care of themselves, or they're on some kind of hospice program is another sort of model people are very familiar with that works really well. What people are not used to and what health systems are trying to figure out is those more acute cases. So any sort of treatments that have historically been in brick and mortar or acute sorts of care, things that we've always said, yes, you should spend the night in the hospital for this, or because you're on IV antibiotics, for instance, we're going to do that inside the four walls of the hospital. So yes, there are tons of operational challenges, and it's not just getting the caregivers around, right? It's also, in the case of like hospital care at home, it's also getting there's a kit that happens that gets set up in the patient's home where the patient can think about the call button. It's like an iPad, and they have a way to talk to a virtual nurse on demand. So there's this whole kit, and that also includes the remote patient monitoring devices for their vital
Mhm.
signs. So all of that has to get set up before the patient can go home. There also has to be ongoing medication delivery. Often labs have to get drawn every day. So there's lots of care that happens in the hospital that also then has to get delivered at home that are like errands. Even sometimes people are getting meal delivery as well, right? Because they're not able to cook for themselves and they need that. So anybody running a complex program like that has stuff and people that need to get to the patient's home at the right moment. And so those logistics are very complicated, very hard to do. The other sort of hidden issue with care at the home is we have to make sure that care is equitable, right? And that everyone has access. And for some folks, their social determinants of health issues mean it's hard to deliver care in their home. They might not have a safe space, or their home might not be able to support all of those connections. Wi-Fi or even electrical systems have to be up to a certain standard in order for all that equipment to be plugged in. So sometimes there are barriers to caring for people at home that mean they should probably stay in the hospital. And so part of the movement is to make sure that that care is accessible to everyone. So our health system's still involved. Yeah. So there are amazing health systems like Atrium Advocate that have really thought broadly about their care at home model. And what that means is they think about sharing one infrastructure across all the types of care that can be delivered at home. And that makes that return on investment, but also that logistics management much easier, because now every team that's doing care at home is working together to deliver the care. And it just means you can scale. And so they are the biggest program in the country. They see probably 150 patients as an average daily census, huge program. And they've moved even observation patients into the home. So observation is a thing that happens if you go to the ER and you're not sick enough to be admitted into the hospital, but the physician wants to keep an eye on you. That sort of observation care can happen in the home, and Atrium Advocate does that in a really elegant way. So yes, systems are still trying to do this. The question is, how do they scale the programs to be big enough to meaningfully impact their bed shortage? And that's the problem to solve between now and 2030.
Of
So it's a
course.
challenge. Yeah.
And operationally speaking, I mean, you don't have all your staff, all your equipment, all your systems on. The patients are not inside the one same building. It's
Right.
tougher to. I mean, as you said, the logistics around it, and it seems tough. So it makes a lot of sense.
Yes.
I
Yeah.
think I think MedArrive has a great platform to help solve this issue. So that's great. Regarding like scheduling, routing, like the real world logistics, as you said. So you said MedArrive highlights like smart scheduling, right? And routing as a core. That's the core of the platform. And that makes sense, of course, because home-based in care needs that more than anything. And that's a constraint. Is there like a constraint, depending on distance, timing, provider availability, so on and so forth? What makes scheduling in home care so much harder than people expect?
Yeah. So it's really interesting. Over and over, we've seen that most programs have someone who's working in that centralized scheduling who
Mhm.
is a genius about scheduling. So that person tends to know the community really well. They know that that road is behind the Walmart, and then you take a right and you go down this farm road, and this is where the patient is. They know the ins and outs of that community. They know their providers really well. They know the care really well. And the challenge for them has been that's a lot of variables to manage in your head.
Yeah.
So they'll have the big question for them often, the most sort of stressful things that happen are, we have 3 new admissions today. Can we take all those patients? Do we have room? Not just today, but tomorrow and the next day and the next day to take that patient in. The other thing they manage all the time is someone calls out, right? Someone's sick, someone's late, someone has to cancel part of their shift. Now, how do I reshuffle the day? So at MedArrive, we don't ever believe that there's no world in which you don't need the humans. Our job is to help take away the decisions that are easy to make and let that person coordinate things that are a little more difficult and complex, and often allow these programs to scale much bigger with the staff they have. So what our automated scheduling does is we put in so many variables into our algorithm, including what type of visit is it, who's credentialed to do that visit. We see in home care, you have someone who's in the home sitting there with the patient real time. And then you have another provider who's going to come in virtually, either a nurse practitioner or maybe a physician that needs to join the visit for a bit of time. So we can tether those visits together so that virtual provider gets an alert. Hey, we're ready for you to join that visit. It's scheduled at an offset so that we give that person in the home time to get started with the patient and get the patient comfortable and ready, and then have that virtual provider join. So all of these flavors of visits are configured in our system. And then our system also, we use the same technology Uber does to kind of look at traffic patterns and update drive times in real time. Before that, what happened was people would maybe look up a drive time, but most programs just say, we're going to assume everybody's going to take 30 minutes to drive somewhere. And then they also made assumptions around how long should the visit be. And that's a typical thing that happens in healthcare. One of the sort of unexpected benefits that happens when people first engage us. They're most worried about get me some efficiencies because providers get really irritated if they go to one part of town and then another part of town and they come back to this part because they're in the car a lot, not a satisfier.
Uh-huh.
That's usually the first problem they're solving, and safety. We want to know where everyone is. We want to know that every visit happened. What they find really quickly is usually their visit times are off. We watched when we went live with our very first client, we sat together and watched as visits completed in 30 minutes that were scheduled for 60 minutes. So what they were pretty quickly able to do is say, oh, we should allow 40 minutes for these visits and then take that 20 minutes back and let our capacity, show that we have more capacity for more patients. So it's all of these variables that are happening inside our system. Our system's also able to look at a day and say, if you move these 5 visits or 6 visits, now you'd have all this other capacity that you're not aware of. And so our system allows, and organizations can do this the day before, the day of, whenever they want. They can sort of get an optimized day. And so that's really interesting.
No, I was going to say, you actually answered my follow-up question, because I was going to say, how do you optimize so it's not, so a visit doesn't, or in the worst case scenario, it feels like it's over optimized. And then you answered it. That's great.
You can also see in our tool if a visit is running long, because what you don't want to do is have people end a visit early when they need to be there. So when a visit is running long, that's visible in our system, and the system is up, here's what you do. Send this other person to the next visit, or let the next patient know that they're running late. You can see that right in real time, which saves a lot of back and forth. Many of these programs are using like Slack or Teams to communicate in real time about what's happening. So imagine you're in front of a patient in the home and you're trying to Slack back and forth or use Teams back and forth to say, I'm going to run 10 minutes behind, let my next patient know. All of that noise goes away so that provider can focus on the care they're giving. And then when they go back to their car, they know that the rest of their day has been handled.
That's perfect. No more beepers like in ER. So what happens when something doesn't go according to plan? You just said it, right? There's some automations, but what happens if there's no one available someone gets delayed, there's no one available to go to the next care? What happens? What's the steps? What are the steps there?
Yeah, it's really interesting, and different programs handle that different ways. So sometimes in the hospital care at home setting, you have to see everyone. You don't have an option to not, get to that next patient. So we give people tools to do that, and we work out the workflows and the what ifs as we're setting up the system. A good example is many of those programs have clinical staff that are in a command center that could be deployed out to the home if necessary. And I call that break glass in case of emergency providers, where the system will not tee up those providers unless there's absolutely no one available. And then it will add those providers into the schedule and say, okay, this person who usually sits in the office is going to go out to that next visit. And so that's one way we handle that. In other use cases, right, with home health, there are patients whose visits can be moved to the following day or later in the day, and it doesn't impact their clinical quality. So our system tees those up as well and says, okay, I'm going to move these 3 visits to tomorrow. I'm going to keep these visits on for today because these patients have to get seen.
Well, when MedArrive talks about command center visibility, like having all the dashboard and everything available, is that like a real-time visibility that for all the providers? And is it so important for in-care at home operations in general?
Yeah. What happens is there's like a vertical bar that runs at the time of day, right? So you can see where your visit is and what status it's in. Is the provider en route? Are they on site inside the home? Have they completed that visit? So everything is visible in real time. You also see a live map of where all the providers are and where all the patients are. So you know where people are. Safety is a big consideration for healthcare workers. Again, and we've had conversations around, when you order Uber and you can see the driver coming and you know where they are. Occasionally people will ask us for that technology, and we always say we're willing to build it, and that's very easy to turn on. However, we recommend against it because it's very different having someone come into your home than it is for someone to drop off food. And we don't want people to necessarily know where providers are out in the community. It's just a safety issue. So, but knowing where people are, knowing how long they're supposed to be there, and then if they're there a longer period, what's happening, and being able to know that is really a game changer for these in-home programs. We found that we were using paramedics and mostly to be in the home. And I will just say, and I'm just a big fan of EMS and paramedics little biased because I was in that world for a while, but they are amazing in a patient's home. They're not phased by anything. They've seen it all.
Hmm.
They're the least judgmental folks in the world. They just go in and create an amazing relationship. But not everybody comes with that, right? If you're in home health or you're a different kind of modality, you're not someone that's seen everything necessarily, and you get really uncomfortable in someone's home, no matter where it is. So making sure that providers are safe and that they know they're safe is really kind of one of the founding things for MedArrive around making sure they feel great about their day.
That's great. And there's a lot of healthcare teams that are still making decisions from reports that are maybe stale, or by the time they see them, they're just not relevant anymore.
Yes.
What changed when leaders can see what's happening today, like with your platform, and not just what's happened last week or last month?
Yeah, that's one of my favorite parts. So one of the things we do when we go live with a customer is, and we tell them this: we're going to watch your operations with you. We go live on site for go lives because we really want to make sure people feel comfortable with the technology. Also, we know that providers want very simple tools in the field. We want to make sure that they're very comfortable with how the tech works and that we help them sort of overcome any challenges. But our tooling for the providers is extremely simple. And in fact, we have auto arrive and auto complete so that they don't even have to say they've arrived. The tool knows you're within 100 feet of the door. I'm going to say that you've arrived. So we go live and on site. And one of the reasons we do that is we watch the operations live in real time that first couple of weeks so that we can feed back to those leaders. Hey, this is what we're seeing from our experience. And these are some things you might want to think about. There's so much data that comes in that real time basis. And managers get really excited around like seeing the differences between like, wow, Andy's visits take 30 minutes longer than Greer's. What's that about? And
Hmm.
often there's great reasons why Andy's visits take 30 minutes longer than Greer. Sometimes Andy's doing a more thorough job than Greer, and he's really, taking the time with the patients. Sometimes it's at Andy's, like I would be in the home, right? I'm a talker. So sometimes it's I'm having conversations a little too long. So those management opportunities at the individual level, but also then at that visit level, how long should this visit type actually be? Those are the things that are getting live in real time. It's very obvious and it's very easy. And then again, we're there as a consultative help to make sure that people are seeing those messages and thinking about really, we love to talk about experiments, right? So experiment, for instance, with arrival windows. If you think about it, and my parents have experienced this, in healthcare, what you don't want is what we call cable guy scheduling, which is your provider will be there sometime between noon and 4, right? My parents are baby boomers. They will tell you they are very busy. They have so many things going on, Andy. They got their show at a certain time. They have a hair appointment. They don't want to wait 4 hours for a provider to come to their home. So we really encourage people to tighten their arrival window so that you say to the patient, they'll be there between noon and 12:15. But it takes some operational change for people to trust that they can actually do that and be right about when the provider will be there. So that's some of the change management we do in those first few weeks to really help our clients understand what experiments they can run. And we'll say, try shortening your arrival window for 2 weeks. Let's see how it goes. And then let's move forward, because the longer your arrival window, the more cancellations, right? And the most inefficient thing that happens is a provider going to a home and the patient canceling the visit once they're already there. That is the worst thing that can happen in the day.
And it's the value of data, right? If you have the data, you can improve your processes. Without data, without measuring, you can do anything. So it
Yes.
makes a lot of sense.
Yep.
Perfect. So switching a little bit to mobile tools, MedArrive seems to be designed to be around the field, right? So assigned visits, routing, patient details, documentation, time tracking, so on and so forth. Is it an app? Does it have an app? Is it a responsive website that adapts to your mobile phone? What does the field provider need from the software when they're out on the field in the real world delivering care?
Yep. That's a great question. So there's multiple components to the platform. There are our web applications are things like that predict tool that tells you when does the patient need to go and where do they need to go. That's a web application, integrates with Epic and Cerner, shows up in your tool. It can be integrated to the degree that your team is working in Epic or Cerner and we're just surfacing within that workflow. Or it can be a MedArrive screen surfaced within the sort of iframe of the EHR. Or it can be just a data integration and people are swivel chairing to MedArrive. We find that most people want to be deeply integrated with the EHR, and so we support that and have a playbook. So for your team that's in the health system setting or in the home health setting, That's their experience. In the field, providers have a mobile app that's on their whatever device they use for work. So many of these providers already have an iPad where they're doing where they're accessing their EHR, and so or they use their mobile phone. It depends on the model. And so we support any device. It is a web app. Sorry, not a web app, a mobile app that they download onto their phone. When
Okay.
they clock in, it starts tracking their location. One of the big pieces of training we do is two things. One, make sure to clock out so we're not tracking you after work when you're headed to, go out to dinner. And the second thing we make sure people understand is we give the client data to prove all the data they need to prove that the visit happened where it was supposed to. But we do not keep or give tracking where providers drove. And the reason for that, again, is privacy. We don't want any sort of, we just feel like that's privacy data that we don't need to do. So the provider has on their mobile app their schedule. They get notified of any changes that happen or any other system notifications that need to be broadcast by the system. They can see some details about the patient, though what I would say is it's not a substitute for their EHR, but they can see high level, what are you there to do? Any tasks they're required to do in the home. And then they can see their route. When they click that they're en route, it automatically pops up Google Maps and they're routed the most efficient way to their visit. And they can see their schedule and they can make changes to their schedule if that's allowed by their settings. So some organizations, if you're a full-time employee of like a health system, your supervisor may have to make the schedule changes in your app. If you're a provider that's working in home health, usually you have control over your own schedule. And providers can set things like their lunch. They can set a block like, hey, I'm not available from 2 to 3 because I'm going to my kid's school for a
Uh-huh.
teacher meeting. All of that they can do in their app. They can also set things like, I'm going to go to an assisted living and have 5 visits in a row with 5 different patients at this one place and make that a visit block so that the system knows like, oh, they're going to stay at this place, but see all these
Yeah.
different people.
That is, I hadn't thought about that. Like going to one place that has a lot of patients, that's a win for sure. That's great. So healthcare technology sometimes fails when there's like one more screen or one more login or something in someone's day, right? How
Right.
do you design a software that actually supports the care team instead of becoming another operational burden?
Yeah, that's why we're really passionate around integration. We prefer to be so deeply integrated that people don't even know they're on a MedArrive tool, that they just are in their ER. We feel like that's the most frictionless experience. And we want providers to have the most satisfying experience. So, again, clicking around is not a satisfying experience. So all of that work that I just mentioned can be surfaced within the EHR, and that's our preference. Where someone doesn't wants to have a swivel chair experience, we're happy to do that. And again, that's just a data exchange, right? We can exchange the data around visits and appointments however we need to. We have a client that's going through an Epic integration right now. And so we're working with their older system. And so that's just a data integration. And they're using MedArrive as a swivel chair because they're going to integrate it once their Epic is ready to integrate. And that makes total sense, right? So there are reasons and times when you aren't going to do a deep integration. But generally speaking, that's how we like for the tool to work. What's interesting is, and I'm really excited to see how this evolves over time. I've noticed a trend where in AI, when some of the automated tasks happen, users sometimes have trouble believing the task happened if it's so automated that just the data changes. And so we're really working with our customers on kind of a crawl, walk, run of that, where at first people watch the AI happen in some way. And so we'll show a little, it's almost, it kind of feels like the dots when someone's texting, it almost shows hey, something's happening. I'm reaching out. I'm making this phone call on your behalf so that people get the idea that there's a task happening by AI. And then they see the updated data, because for many users, AI is so new and it's weird to think that there's an AI agent making a phone call on my behalf or doing something on my behalf. We're noticing that there's kind of a need at first for people to see it happen. And then over time, they get really comfortable and say then we can remove that visual and just update the data and people know it happened. It's interesting.
You're going ahead of my questions. This is impressive. I was going to ask about how does a successful implementation look like between MedArrive and a care facility?
Yeah, I think, the most successful piece is the change management piece, that people really adopt all of the tooling and start to make, I know we've done a good job when people start making operational changes. when they start changing visit times, when they start experimenting with how they engage their patients because they're realizing, wow, we should really solve our cancellation rate, or wow, we can use MedArrive to solve this other problem over here. That's when you know people have been implemented well. So that's why we're really sticky with the change management, and we're on site and we're building those relationships as we go. We
Mm.
really love to have an on-site conversation before we even sign a contract. We like to go on site and understand the workflows at depth so that, one, we can start building relationship with our end user community. Two, allaying any worries about AI taking anybody's jobs, or even this, much of our tool is just algorithmic and not AI. And even that, right, seems like voodoo magic. And so really helping people understand how it's going to work, even that early, and starting to push their thinking on, you're doing it this way today, what if it was like this tomorrow? But
Mhm.
also making sure that whatever's in their workflow is covered by our system. We have gone into a new client and found they do something we haven't actually seen before. How do we accommodate that in a way that makes sense? And so we do that on site, and then we come back on site to go live to make sure that, people really adopt the tool. And again, we're coaching all the way along with all the different user types, saying, hey, here's what I'd be thinking about if I were in your chair right now.
That's great. I was gonna ask something about AI, but you already mentioned it, how it implements and the stuff that you're doing, right? AI is everywhere. So I'm gonna move forward to what I'm really interested in, like how, if you could change one thing about how healthcare organizations launch care at home programs, what would it be?
Oh, that's such a great question. One
It's a
thing.
tough one, right?
It is a tough one. I think the one thing that I would change is I would have health systems, and this is tough. All right, I'm gonna pick two. This is real. This is both of these are tough. I don't want to say impossible, but tough. One is, again, many health systems have a home health either joint venture, or they have a group that they're affiliated with, and they're affiliated with the home health in their community. They also have, again, specialty groups starting to think about in-home care or operating small programs or pilots. And then they might have hospital care at home. If I could wave a magic wand, everyone would start thinking about driving care into the home in a holistic way. Let's think about organizing that under one leader, having a strategy around it, and really leveraging the infrastructure across so that a nurse or any kind of caregiver can do a home health visit, and then they can do a infusion visit, and then they can do a hospital care at home visit, because you should be leveraging those resources across to eliminate the waste and to make all of these programs more transparent and more efficient and effective for patients. So that's the first thing I would do. The
Okay.
second thing I would do is probably impossible, which is we have a pattern of the way that we discharge patients. So what happens in hospitals is usually there's a morning round where the care team gets together and talks about, okay, these are the 3 patients who are going to discharge from this unit today. And then everyone knows that at 7 a.m. But the patient doesn't leave till 3 or 4 in the afternoon, and only on Monday through Friday, if they have any needs at home. And I think that's a disservice to patient care. I would like to see us, and this would require everyone in the community changing and everyone in the health system. So again, a little hard to imagine, but we should be discharging patients. I'm not a fan of like the 3 a.m. discharge, not saying that. But what I am saying is, if we know a patient is going home at 7 a.m., why aren't they gone by 9? And some of that is just the way we've worked our day in the health systems, in the hospital space, and the way we sort of process orders and the way we've sort of organized the work. So I think that's a problem. And why aren't people going home on Saturday and Sunday when their family can more easily get them there? It's really hard for families to be, at 3 o'clock on a Wednesday, they've been there all day trying to get their parent home. And then the nurse comes in at 3 p.m., hands them these discharge orders, runs through them as fast as they can because they're pressed for time. And you've been waiting all day long for really no good clinical reason, usually because of just delays that are happening inside the hospital. So I would love to change that too, but that's really hard.
Let's start a nonprofit and start working with local communities and start changing it. I love it. It's a nice dream.
Yeah.
And I agree with you. You'll be fantastic to do so. Where do you think that Here at Home is heading over the next 5 years?
Here's what I think is really hard headwinds wise. If I'm a health system, I was just at a conference about a month ago with health system COOs, and oh my God, is that a hard job? Those folks are hearing, there are so many. CMS is doing I will say some amazing things about interoperability and healthcare data there that would be amazing for our healthcare system. But we're also coming out with a lot of messages around potential changes where health systems aren't sure if those changes are actually going to take effect or not, or how those changes are going to take effect that materially impact the way they deliver care. One small example is that after some orthopedic surgeries, there's a potential rule coming out that patients would need to be seen 9 times within a certain time frame at home. Drives care into the home, great. But is that rule going to actually happen that way? When is it going to hit? And so health system COOs are battling so much data and information from the federal government around potential changes where they don't know whether to make those changes now or not. They have that combined with major reimbursement cuts that are coming in 2027 that start, and they're battling the AI sort of tsunami. And we're a company that is part of that tsunami, but I really feel for health system leaders who are trying to evaluate a zillion AI tools, not just in, we're doing a operations logistics play, but there are tons of clinical tools that are coming out, tons of things in the room that are coming out, and leaders are trying to adopt AI just in their own day-to-day work life.
Yeah.
It is overwhelming. And I don't think we're really clear yet on what is completely safe to do with AI and what's still on the sketchy side, right?
Yeah.
So there's all this innovation, all these ideas, and as a health system executive, how do I choose? So that those headwinds mean while we have this dire need to move care into the home because of the bed shortage, can health systems focus on that problem right now? It's very difficult. Very difficult because of all the things that are hitting them at the same time. I've been in healthcare 30 years. I've never seen a harder time to really innovate inside a health system because of how of how much is going on at one time. It's a lot.
It's changing too fast. I mean, 3 years ago, it was, I want to say slow because it was slow compared to now, but it wasn't slow. It was fast paced. But now it's just insane. Everything moves so quickly. I agree with you. It's tough.
Man,
It's tough to be creative too.
No, it's so right, Andy. And companies are standing up every day. In fact, it's so funny. We get, we all of us, right, read the news. So many news about some company getting, a gazillion dollars of funding for an AI thing in healthcare. And it seems great. But I think the other caution or worry that I have is the number of companies, and in our space, it's happening all the time. Companies that are coming with people that are very smart, very gifted technically, understand AI, but they don't understand healthcare. Yeah. And that's going to be a challenge going down the road, because if you don't understand, healthcare is highly regulated and there are tons of safety and clinical concerns that if you aren't aware of those, it seems like, well, why can't AI just, well, because there's a lot we're trying to manage here in the healthcare space. So I think if people can look for companies and understand who on your team really at depth understands how healthcare works, that's important, because there are a lot of companies getting founded and funded that don't understand. And while in the startup community, that's a value, right? It's the disruption. Let's disrupt it all. And that is a beautiful thing. There are also real limits to what can happen in the healthcare world. I'll give a quick example from MedArrive early days. When we were providing care in the home, it was hard for our team to understand how credentialing works. So credentialing is a thing where if I have a new nurse and maybe that nurse is already credentialed with a health plan in Arizona, say. If I'm going to do new work with that nurse in my company and that nurse is going to work under my provider ID, I now need to get that nurse credentialed with the state Medicare and Medicaid. I need to get that nurse credentialed with the health plan I'm working with to do the work that I'm saying we're going to do. So that can take 90 days for a nurse credentialed to go into the home and provide care. And that's an important process to follow. As a startup, if you think about it, I get a contract. I want to start operating that contract. I need to hire these nurses. I need to get going, but I need this credentialing. So how do I manage the upfront investment of hiring people and waiting 90 days to get credentialed before they can actually start visits in the home? How do I organize my work to manage that? And in the early days of MedArrive, there was a belief from some of the leadership that weren't really deep in healthcare about well, just call the Medicaid agency every day and ask about the credentialing. And anybody that's been in healthcare 10 minutes knows if you call the state Medicaid credentialing arm every day, your application goes to the bottom of the pile. Those folks they don't care about your company or that you're making money. They have a pile of things to do and they go through the pile the way they go through it. It's a government bureaucracy, and startup hustle does not work in those. It would be a bad idea to do it. So it takes a while there's this beautiful tension, right, of startups that are like, let's disrupt it all with the reality of delivering healthcare. And so I love that tension. I love to live in that tension, but it's real.
I
So
know how busy you are in the life of a CEO. So I want to wrap it up with a quick lightning round, if that's okay with you. So just think whatever's in your head, the first thing, don't overthink, just
all right.
quick, fast questions. Okay. So most overrated thing in healthcare technology right now.
Most worrisome?
Overrated thing in healthcare technology right now.
First thing that comes to mind, probably meeting summaries.
Okay. Yeah,
Yeah.
that works. Most underrated operational problem in care at home.
Logistics of supplies.
For sure. We've talked about it all podcast long. Makes sense. One thing software companies need to understand better about healthcare operations, and you just said it, right? You need to understand healthcare first.
The complexity and how backward it really is.
Perfect. One thing healthcare organizations need to understand better about software implementation.
Change management. Everybody kind of knows it and gives lip service, but really getting people to optimize the use of the tools they have it takes a lot more time and energy than people want to think.
Yeah. What separates a scalable care at home program from one that gets stuck in pilot mode?
Great question. I think siloed care at home programs. So not having programs sort of aligned together to deliver together.
Okay. Almost done. The future of care at home in one sentence.
We have to figure out how to better deliver care at home because otherwise people will not actually get care. There's not enough care available in our brick and mortar settings in the next few years to accommodate the patients.
Perfect. And what would you be doing if you were in healthcare right now?
Yeah, I'm actually working on a side podcast myself around repair work and how people repair in their own life. And some of that is healthcare related and some of that is not. So I would probably be doing something in that vein if I wasn't doing healthcare.
Good. Not comedy though.
No, I mean, look, if I were that good at comedy, I wouldn't have this dumb job. You know what I mean? I'd be on a Netflix special. Yeah. So I loved my time doing stand up and wouldn't trade it for anything. Gave me so many skills. And I loved it. But yeah, I am passionate around bringing more depth and meaning. And some comedians are brilliant at that. And I wasn't. I will go to the lowest common denominator, unfortunately, when pressed. And so I find it easier to do that when I'm having a more serious but fun conversation.
Makes sense. So Greer, thank you so much for being with us. It was a great conversation. Appreciate you getting down the operational side. Just the vision, right? It's just like day to day, the logistics, the routing, the visibility, the platform per se. So where can people learn more about MedArrive?
Yeah, MedArrive.com, which is, we are still updating our website, but it works. And so you just go to MedArrive.com, contact us. They can email me, Greer@MedArrive.com. Happy to answer any questions or listen to feedback and any ideas that folks have.
Thank you again for joining us. And thanks again to everyone listening to Deep Current. If you're interested in conversations about healthcare operations, technology, and the systems behind the better care delivery, stay tuned for the next episode. Nice talking to you.
Thank you so much. Thanks for having me. It was great. Thanks so much.
For sure.